Yes.
Yes.
All right. Wonderful. Okay. All right. So, well, I didn't get enough time to prepare for all of them. So what I've done is, anyways, this is going to be like little longer. So I have done for schizophrenia and mood disorders, and I have also compiled the treatment plan for schizophrenia, but I could not do it for mood disorders, but I have compiled all the ICD-11 criterias and like what are the mood disorders included in ICD-11 as well. All right. So in the next lecture, we can see the treatment plan for mood disorders from Maudsley and NICE guidelines and the other disorders as well. All right. So, yeah, let's start with this one, schizophrenia and other primary psychotic disorders. So, in ICD-11, this is how they have mentioned it. So they have this is sixth chapter of ICD-11, and these are the code for the various psychotic disorders that they have compiled. So we have um, so this schizophrenia comes under schizophrenia and other primary psychotic disorders. So we have here the following: schizophrenia, schizoaffective disorder, schizotypal, acute and transient psychotic disorder, delusional disorder, and 2Y and 2Z. All right. So, all right. So, any one of you, could you remember any of the criterias of schizophrenia? So, I'll give you a hint of it is from A to E. A, B, C, D. No, sorry, A to G.
Okay, I don't know about A to G, but generally for 1 month, if you have psychotic symptoms, so hallucination, persistent hallucination, especially auditory, delusion or thought disorder, I think they're sort of like the major
Yes,
symptoms. You've got other symptoms. Um, so there would be, passivity phenomena, that kind of stuff, and then there's negative symptoms as well. Sorry, I don't remember everything, but from what I remember. So negative symptoms would be amotivation, avolition, alogia, asociality.
yes, that's correct. That's correct. So three of the symptoms that you told come under A to E. So let's just see it here. So in schizophrenia, when we talk about schizophrenia, we have symptoms from A to G, and ICD-11 says that A to D, like one symptom, so total of two symptoms should be present, all right, for a duration of more than equal to 1 month, and one symptom needs to be from cluster A to D. So any of one symptom should be present from here, and one symptom from A to G. So A, B, C, D, E, F, G. So you told we have delusions, hallucinations, and experiences of influences, passivity, or control. So three of these symptoms are from A to D, which is an important cluster, and we have disorganized thinking as well, which is included in this. All right. And then we have, as you said, evolution. So those all come under negative symptoms. So you have flat affect, decreased speech output, decreased emotional feeling, withdrawn from the world. These are the negative symptoms. Then we have disorganized behavior and psychomotor disturbances. For example, catatonia-like symptoms. So in catatonia, patient could be in stuporous position, not saying anything, not speaking, not walking, just staring or being at one place. Sometimes there is complete refusal or complete, not just refuse. We wouldn't say refusal, but they won't poor oral intake, very poor oral intake. So, so again, over here, from A to D, these are most important symptoms. So one symptom needs to be present from here, and one symptom needs to be present from all of this cluster. Um, one symptom, and for at least 1 month, to call it as schizophrenia. So, all right. Okay, so in ICD-11, what they have given is they have given specifiers, all right? So they have given longitudinal specifiers and cross-sectional symptom specifiers. So in longitudinal course, they said, so there's a big difference in ICD-10 and ICD-11 in this sense. ICD-10 did not describe symptoms at first episode, multiple episodes, but ICD-11 has given this specification. So we have first episode, current or most recent episode. So first episode is the first time, and usually it is said less than 5 years. And in some books, it is less than, sorry, yeah, it is around 2 years. So this is what they say. And first episode, and then we have multiple episodes. So to call a schizophrenia episode to have to be of multiple episodes, there should be at least 3 months gap between two episodes. So after a person had schizophrenia, they should be in remission for 3 months, and then another episode precipitates. That is when we called it, they are having multiple episodes. If another episode precipitates before 3 months, then it's the relapse of the same episode. We are not going to consider it under multiple episodes. All right, are you guys with me?
Yep.
All right.
Yep.
And then, okay. So when do we say it is continuous? So, okay. So these are the guidelines from different books. In ICD-11, it says if the symptoms have persisted for at least 1 year, then that is when we say that schizophrenia. So how do we write the diagnosis here? So we say schizophrenia, uh, first episode, currently symptomatic. So let's just complete the cross sectional as well, and then we will write the diagnosis. So we saw the longitudinal course. The next thing that we see is cross sectional course. In the past 30 days, how was this person? So currently symptomatic. That means the criteria that we talked about are met from A to G. So two symptoms that we require for a diagnosis are met. In partial remission means that some clinically significant symptoms remain, and most of it has been in remission. So most of the time, the patient has been in remission and have partially regained their functionality. So they have started to go to work. Maybe not they're not doing the work in their home like they used to do before, like in complete remission, but they are still functional now. And in full remission, there are no symptoms that are remaining. So, how do we write the diagnosis? We write the diagnosis, whenever we are writing the diagnosis, we say schizophrenia. Let's say the patient is in first episode of schizophrenia. Schizophrenia, so the first is longitudinal course specifier, that is first episode. And then let's say patient came to us with symptoms, so currently symptomatic. This is how we write the diagnosis whenever we are mentioning it in any reports. So if they are in partial remission, we'll write schizophrenia, first episode in partial remission. All right? Okay, so this was the first one, schizophrenia. Now, before we go into the details of schizoaffective disorder, can any one of you tell that what do you understand by schizoaffective disorder?
There's a significant mood element involved. I don't know.
Yes, that's right. So can you describe the mood element?
So they're either depressed or sort of high, but like they would have, if they didn't have schizophrenia, they would have a mood disorder. But it's since they have both of it together, then it's called schizoaffective disorder.
Yes, that's correct. So the criteria should meet both criteria for schizophrenia, which we just discussed, and criteria for a mood disorder. Now, this mood disorder can be anything. It could be a depressive disorder, it could be a bipolar mood disorder, or it could be, let's say, bipolar mixed mood disorder. So this is important. So when we go into when we see the ICD-11 criteria for mood disorders, you'll understand how to see whether the patient is meeting the mood disorder criteria or not. But yeah, you're right there. So let us go into the understanding of schizoaffective disorder. Now, number of symptoms. So we need to have schizophrenia. So symptoms of schizophrenia and mood disorder, and full diagnostic criteria of both of these should be met. All right. Now, they can either present together, that is simultaneously, or this is important, occur within a few days of one another. Now, this is important because if there is a significant gap between the two, then you cannot call it a schizoaffective disorder. It will become a comorbid disorder. So let's say a patient presented to you with schizophrenia, and then after a few months, they also developed a mood disorder. That is not when you call schizoaffective. So this will be schizophrenia with comorbid mood disorder. So whatever it is, single episode depressive disorder or bipolar disorder. So this is important. Together, simultaneously, or occur within a few days of one another. All right. Now, when we talk about mood disorders, we can have moderate depressive episode, we can have depressive episode, we can have manic episode, and or mixed episodes. We'll look into how do we classify these and what are the symptoms clusters that come under these episodes later in the mood disorder part. Um, all right. Okay, so it does not matter which comes first. So any can either mood or schizophrenia, doesn't matter. So that means the symptoms for schizophrenia needs to be present for 1 month. So total duration needs to be 1 month. So okay, can anyone tell me for mood disorder, let's say for depressive episode, what is the total duration that is needed to be met in order for a person to be considered having a
I
depressive
think
episode?
2 weeks persistent pervasive symptoms.
Yes, that's correct. So it is 2 weeks. But for schizophrenia, we need to have 1 month. So that is why for schizoaffective disorder, at least 1 month duration needs to be there because we need to meet the full criteria of schizophrenia as well. All right? Yeah. So this is how like I have made a small table to understand, like small chart to understand that. So let's say for 15 days there is it just met the full criteria for severe depressive episode, and then for a month it met the full diagnosis criteria of schizophrenia. Um, All right. So this is like this is how would you differentiate if a person is having bipolar psychotic or severe depressive psychotic disorder? So if in bipolar disorder we have a specifier for with psychotic symptoms. Let's say bipolar depressive with psychotic symptoms, and we also have specifier in depressive episodes with psychotic symptoms. Now, how would you know whether this is not bipolar with psychotic or depressive with psychotic and it is schizoaffective? You will see that the full diagnosis criteria of schizophrenia are met. So this is important, the diagnosis criteria that we just discussed. And if so, in case of schizoaffective, this is going to meet. But in cases of bipolar episodes or depression with psychotic symptoms, schizophrenia um, diagnosis is not going to meet. Criteria is not going to meet. All right. Okay. So anyone who can tell what do you understand by schizotypal disorder? So we covered two of these here: schizophrenia, schizoaffective disorder. Like, do you have any questions here? Do you want to discuss something here? Anyone?
No,
All right. So, how about schizotypal disorder? What do you think it is?
I don't remember. I remember the personality sort of disorder. You know, they had schizoid personality and schizotypal. I think that's all I remember.
Yeah, yeah, yeah. There is like a
I don't
schizotypal
remember it anymore.
personality as well. which like carries the schizotypal traits. That is true. So that, yeah. So you can say that there are some of the traits of schizotypal personality that will be present in this disorder. Now, let's just discuss this here. So when you're not able to fit a person in any of these criteria, that is schizophrenia, schizoaffective, delusional disorder, and you find that there are some strange symptoms that are present in patient. And we will discuss what these symptoms are. Um, then we fit them into schizotypal disorder. Now let's just see what it is about. So ICD-11 writes that, so they have given list of 8 symptoms from 1 to 8. So they say that several of the following 8 points. They do not say how many of them. They just mention several. Several of the following 8 points need to be present for more than or equal to 2 years continuously or episodically in order for a person to have a schizotypal disorder, right? And it is important. Okay, I forgot to mention in schizoaffective and schizophrenia, in both of them, impairment will be present. So, impairment in what all domains? In personal, family, social, academic, occupational, one or more domain. So impairment will be present in schizotypal disorder as well. So let us look into the symptoms. So we have constricted affect. So for example, general appearance of the patient would be cold and aloof. Then poor rapport with others. They would usually have a tendency of social withdrawal. Behavior and appearance would be very odd, and usually they won't be aligning with usual cultural or subcultural ways of thinking and well behaving. Unusual belief or magical thinking. Now, can someone tell me what is magical thinking? Example of a magical thinking? Any example is fine. What is magical thinking?
Um, Things will sort of happen just for themselves. I can think of examples, but essentially um, things that are not very logical. Your thinking is not very logical.
Yeah, it's not very logical. Yeah. So magical thinking is seen in, let's say, psychotic disorders. Yes. Well, we can say in this case, we are referring to schizotypal, not completely psychotic. We won't say that. But yes, ideal, they are present at the idea levels, like paranoid delusions and ideas are, paranoid and suspicious ideas are, suspicion is present at an idea level, not at a delusional level at this moment. Okay, so yeah. So for example, let's say, and it is also present in OCD, very very commonly present in OCD, magical thinking. So this person says that if I open the dustbin, then something bad is going to happen to me tomorrow or my family. So there is no relation of them opening a dustbin and something bad opening to their family. Sorry, happening to their family or themselves. So this is unconnected, illogical way of thinking. This is called as magical thinking. All right. So they will have very odd and unusual beliefs. So these are magical thinking or unusual beliefs that they might be having. You will be turning your head around like, I don't understand how this is even possible. All right. So thinking would be vague, circumstantial, stereotyped, over elaborative, manifested in odd speech but without gross incoherence. This is important because with gross incoherence, then we will be coming under, they might come under thought disorders. And you might not find a proper disorganized thought like one seen in schizophrenia in cases of schizotypal disorders. Like, that is why we are not able to fit them in a schizophrenia spectrum. Sorry, we are fitting them in the schizophrenia spectrum, but we're not able to tell that they have this schizophrenia disorder. All right. So, can you tell what is circumstantial? way of thinking. What is the difference between circumstantial, tangential?
So tangential, they just go off a tangent and they never return back to the topic. Whereas with circumstantial thinking, they'll actually kind of come back to the topic. So if you have asked them about their mother, they will eventually answer your question, but they will give a lot of details. They will get, they talk about a lot of other things.
Yeah, yeah, that's correct. So in circumstantial, as I'm sorry, who's speaking? Is it Dr. Sherry's?
Yeah.
Okay, yeah. As she told that, well, we have a lot of information that is irrelevant information that has been given in case of circumstantial way of well, this comes under, some books say it comes under form of thought disorder. So we'll just consider it under form of thought disorders. In Nancy Anderson's article, I don't remember exact year, but I think it was 20. I don't remember the year, so I won't mention it. So in Nancy Anderson's article, she mentions all of these disorders of thought. So this is form. So we have thought, we have flow, we have form, and we have content, right? So these come under disorders of formal thought disorders. All right. So she says that there is like irrelevant information which is not required to reach from point A to B. So they are giving the answer to you, but they're including a lot of irrelevant information in between. For tangential, they will, so you asked a question, but they will just touch the topic, but they will just go haywire somewhere else. They will touch the topic but never come to the answer of of what you actually asked to the patient. So these are some of the ways that they can present. So the vague, circumstantial, stereotyped, over elaborative speech might be present. Then they might be having suspiciousness or paranoid ideas. This is important. It is at an idea level. It is not at a delusional level. Then they might have unusual perceptual disturbances. So they might have intense illusions or depersonalization experiences, derealization experiences, or even auditory hallucinations. They might have obsessive ruminations. This may include with body dysmorphic, sexual, or aggressive content. Any of these contents might be there. So this is like, like very unusual. Uh, these are very unusual symptoms that we do not usually would see in a schizophrenia or schizoaffective like disorder. So it's not fitting into any of them. So we have just fit them into schizotypal disorder. All right. Okay. So the next one is acute and transient psychotic disorder. So can anyone tell me, like, what is the difference between ATPD and schizophrenia? Like, just I need three differences between ATPD and schizophrenia. Acute and
Um,
transient psychotic. Yeah.
so it's acute. So it has, I think, like it starts within like 2 weeks, etc. So all the symptoms gonna start within 2 weeks. Um, Another difference would be that it actually resolves. I think within 3 months, from what I remember, it's
Okay.
good. Schizophrenia continues. Um, yeah. So and there can be obviously many reasons for it. So that can include like stress, drugs, etc. Right?
So,
Make
so
make
you're saying that there is a trigger for acute and transient psychotic disorder?
Yeah, and
Okay.
we usually do it. Yeah, yeah.
All
We
right.
try
All
to
right.
resolve.
Okay. Yeah. So you mentioned the duration, which is correct. Yes. There are other things as well. Let's look into the table of that. We'll look into the criteria just in a while. So ICD-11 writes that the symptom starts within a few days and lasts for a month, but they never go beyond 3 months. And um, the full blown ATPD symptoms are seen within 2 weeks. So within 2 to 3 days, you will start seeing that this patient, or there will be complaints from the informants that they are behaving very oddly since past 2 to 3 days, and then the full diagnostic criteria for ATPD would be met within within 2 weeks. of the symptom onset. And it never goes beyond 1 month, but in extreme cases, it can go until 3 months. But usually, if what we do is, if after 1 month, if usually, if the criteria of schizophrenia is met, we usually convert the diagnosis to schizophrenia. Right. So ATPD in ICD-10 was not given for 3 months. So, but ICD-11 writes less than, not more than 3 months. But it also specifically mentions that it is most commonly, it usually lasts for 1 month. So ICD-10 writes 1 month, ICD-11 says 1 month, but also mentions not more than 3 months. All right. So, but in clinical settings, we usually go with the 1 month part of that. All right. So this is one difference in ATPD. The other difference is duration. All right. The other difference is, well, the symptoms. The symptoms in schizophrenia or schizoaffective disorder will be stable and fixed. But in ATPD, they will be fluctuating. Even day-to-day fluctuations and even hour-to-hour fluctuations can be seen. What fluctuations can be seen? We'll just look at it. They may have like crying spells, they may have aggressive episodes, they may have delusional episodes as well. So, and these might be fluctuating on a daily basis. This is not going to be fixed, which is seen with schizophrenia. Then, and very polymorphic picture is seen, very polymorphic. So if a patient of a, so if you see a question where they're describing ATPD, but they're not telling you it is ATPD, you will usually see that symptoms of both schizophrenia and bipolar disorder are given. For example, they will say that patient is spending a lot of money or grooming themselves too much, or well, waking up in the morning with increased activity, along with persecutory delusions, well, auditory hallucinations, and very aggressive behavior, very irritable. So all of these symptoms can be present in ATPD. All right. So you, that is why the picture is very polymorphic. You can't differentiate it. So we look into the symptoms in a while. And well, so ICD-11 clearly writes that no negative symptoms would be present in ATPD. In acute and transient psychotic disorder, no negative symptoms are present, but in schizophrenia, they may be present or absent. So, and prodrome. Prodrome is absent in acute and transient psychotic disorder because, well, it starts within days, like within 2 to 3 days, it starts. But this usually have a very insidious and gradual onset. So they will describe a lot of things like, well, he used to have sleep disturbances. He would go wander around. Unusual beliefs were present from before. Even pre-morbid personality might be might be making them predisposed to getting schizophrenia. But in ATPD, this is not seen. So let us just look into the symptoms. We have delusions, hallucinations, so which is same as the well, these four symptoms, if you see, are exactly same as schizophrenia, as the first four symptoms of schizophrenia. And then we have psychomotor disturbances, which was also present in schizophrenia. For example, catatonia. But negative symptoms are absent. This is what ICD-11 write, and symptoms are very fluctuating and they keep changing. Again, ICD-11 does not specify how many number of symptoms needs to be present. For schizophrenia, they did tell 2 symptoms need to be present, but for ATPD, it does not specify that. All right? Okay. So, yeah, it says it commonly lasts for a few days to 1 month and does not exceed 3 months. All right? Okay. Guys, any questions till now? Are we all here?
Yep.
All
Yeah.
right. Okay, great. Now, next up, we have delusional disorder. Now, anyone can like they tell what about delusional disorder? Like, let's say that we'll just ask the differences here so that it will be easier for anyone to differentiate between a delusional disorder and a schizophrenia or ATPD. But mainly delusional disorder and ATPD. What's the difference? Sorry, schizophrenia. Not able to rub it. Yeah. What's the difference? I don't know why it's not working. It's okay. Anyone? Just guess. Like, just take a guess. What do you think? All right. So I'll just describe it. Okay. So when we come to delusional disorder, um, this is important. We have, okay. So one important thing that actually distinguishes delusional disorder from schizophrenia is that delusional disorder, the delusions are related to each other. There may be one delusion or more, but all of them will have a same theme. The theme does not change. This is very important. So they have a story going on which is around the same theme. So, for example, one theme is infidelity. So, everything that goes on. So, they might say that, okay, my husband goes out every day. He may go to work, but then he goes and meets my neighbor. I have seen him there because I saw him bringing back bangles for me from her, let's say from her house. So he bought bangles of her for me. That means he was with her. And then and then they might also say delusions might not are not usually present, but if they sorry, auditory hallucinations are not usually present in delusional disorder. But let's say if they are present, auditory hallucinations will also be of the same theme. Okay, that this lady is calling my husband and is saying me to just get rid of him, and because she's going to be with him. So usually this is what is happening. So this is very, very important in delusional disorder. And whenever we take the history in delusional disorder, we have to understand that the story is the same, but it is not the same in case of schizophrenia. And the another factor is the level of functioning. Level of functioning is usually preserved and better than the other categories. That means schizophrenia or schizoaffective disorder. All right. Level of functioning usually would be preserved. They will be able to do their day-to-day activities. So we discussed about one delusion or set of related delusions for more than equal to 3 months with presence of delusion or set of related delusions, right? Characteristic is remarkable stability of delusions. They are you they do not change. The delusions are going to remain the same, and the content of delusion is usually from here. It could be persecutory, it could be somatic. Somatic means they may say that, okay, there is, like a nihilistic kind of delusion, that I can feel that there is nothing present in my body, all my organs have been rotten, and I am going to die, and I can hear God is calling me, and yeah, and so all of this, like everything will be related. And then we have grandiose delusions, we have jealous delusions, and we have erotomania. What do you mean by erotomania? Anyone?
You think someone is in love with you?
Yeah, so it's not just someone, it is someone from higher status, usually.
Yeah, usually, and it mostly affects females.
It could be celebrity, it could be a political leader, whatever. So that, yeah. Then we have absence of hallucinations, usually, except if related to content of delusions, which we already talked about. For example, tactile hallucinations in delusion of parasitosis. Yeah. Then we have absence of severely disorganized thinking, experience of influence, passivity or control, and negative symptoms. All of these, which are present in schizophrenia, are not present in delusional disorder. And also, affect speech and behavior are unaffected. Okay. All right. So we go on from delusional disorder. Yeah, we'll just look into a little bit of course, little bit into course features of delusional disorder. So delusional disorder typically has a later onset, usually in among older individuals, and have greater stability of symptoms than the other psychotic disorders. And so some individuals with delusional disorder will eventually develop schizophrenia. And premorbid personality disorder is usually present in these individuals. Level of functioning is typically better, which we already discussed. Okay. All right. So this covers our section of for ICD-11 criterias of schizophrenia and other primary psychotic disorders. Regarding other specific primary psychotic disorder and this one, in this case, other specific primary specified primary psychotic disorder. Um, so criteria for schizophrenia are not met, but you can see that there are some kind of psychotic symptoms. So you are not able to fit them into either of these categories. So you just fit them in here. All right. Um, okay. So now let's go into the management of schizophrenia because that is the most important one. All right. So this is the screenshot from Maudslay's 15th edition, which is the recent edition. And it gives the treatment algorithm for first episode schizophrenia. Then it tells us about relapse. If there is a relapse or acute exacerbation of schizophrenia, when you know that the patient was fully adhered, like there was no problem with the compliance. So compliance was ensured. And the second part where adherence is doubtful, compliance is poor, or you don't know about the compliance. All right. Okay. So, all right. Any one of you, let's just discuss, let's just brainstorm first episode schizophrenia. How are you going to proceed in this patient?
Um, Give antipsychotics,
Yes.
psychoeducation. We can go for okay, psychoeducation. We can give CBT as well. I think they psychosis, schizophrenia, CBT nowadays as well.
Mhm.
And definitely, the treatment would be antipsychotics. If it's if they're presenting with psychosis, first episode psychosis, we go for I'm guessing quetiapine or olanzapine, right? Second generation antipsychotics.
Mm-hmm. All right. Yeah.
Uh,
Okay. Yeah, let's say, so how many weeks are you going to give them this? And like my question is, okay, you started with an antipsychotic and you also started with psychoeducation and let's say CBT for psychosis for this patient, but it depends like how, like what kind of insight they might be having then in that case. Okay, so let's you have started them. So after how many weeks are you going to see the response to this antipsychotic?
um, I suppose it depends. It would usually take some time. It usually takes a bit of time.
I'm
So
sorry.
it can take some time. It can take
Mm-hmm.
you know a couple of weeks or more. Slowly,
Okay,
if you
all
need.
right. So, okay, all right. So, I have not written TRIPS criteria here, but we'll discuss it later. So, usually it is so. In order to tell, let's say, antipsychotic is not working on this patient, we usually try them for at least 6 weeks. So, so there are different guidelines. Well, Maudsley says first it says 2 to 3 weeks, and then we see the patient again. And if there is no, let's say there are issues with there are issues and there is no response to the treatment, they say change the antipsychotic. But after that, they also write. So there's like a very contradictory thing that they write. They also write that with resistance to antipsychotics that at least have been tried. So two antipsychotics have been tried for 6 weeks each. Only then they call it well, treatment resistant schizophrenia. So very, very contrasting things that they write over here. So we'll come into your part as well. So you said that psychoeducation is one of the most important things, which is actually given in NICE guidelines, all right? But in Maudslay's guidelines, so how Maudslay tell the treatment algorithm is, so two things: either agree the choice of antipsychotic medication with the patient or carer. So this is the thing. And let's say they cannot take the decision. They say that, okay, you're the doctor, you have to take the decision. Then you have to start the patient on second generation antipsychotic medication. Okay, and we usually choose an antipsychotic medication with which have a long-acting injection formulation. For example, we have risperidone, we have olanzapine, we have paliperidone. Okay, so paliperidone is same as risperidone, right? So, for example, or aripiprazole. So, any of these which have a long-acting injection formulation, all right, and titrate as necessary to minimum effective dose. Adjust the dose according to response and tolerance, and assess over 2 to 3 weeks. So they say to assess over 2 to 3 weeks in the first episode, but it is usually, please remember, it is usually we may assess them for 2 to 3 weeks, then we adjust the dose. We adjust the dose. For example, we increase the dose and we assess them for the next 2 to 3 weeks. So at least for 6 weeks, we have to assess them on the same antipsychotic. This is important because let's say if they are not responding on this antipsychotic, after 6 weeks you're going to change this antipsychotic to a different one. Let's say you have tried the second antipsychotic, you have to do the same thing with the second antipsychotic as well. You have to give the second antipsychotic, increasing the dose according to tolerance and response, for 6 weeks, and then only can you call this patient having treatment resistant schizophrenia. If they have not responded on both the antipsychotics for 12 weeks trial, when you have given the 12 weeks trial with compliance ensured. Right? So there is some issue. Okay, they might have given it 2 to 3 weeks. So they also write here, most improvement occurs during this period. If no effect by 2 to 3 weeks, increase the dose or change the drug. But what we usually do is we increase the dose. All right. Okay. Effective, then continue at the established dose and switch to long-acting injectable. There is no effect, change the drug or increase the dose. Let's say they have not tolerated or poor medication adherence, then in that case, like change the drug or address the side effects of the antipsychotic. And if it is not effective, that when you have called it treatment-resistant schizophrenia, that is when you start the patient on clozapine. All right. Okay. Moving on to, let's say there is relapse of the symptoms or acute exacerbation of schizophrenia, and the compliance of the patient is ensured. You know that the patient is compliant, and how do you know that? It is given in TRIPS criteria. Treatment response and resistance in psychosis. This was a criteria given by I forgot the House et al. In 2017 article, and this is the criteria that we follow, that is TRIP criteria, is that we follow in order for the patient to confirm that the patient is having treatment resistant schizophrenia. So how do you confirm the compliance? There are several ways that they have given, so we'll have to look into that. All right. Okay. Treatment algorithm. Let's say acute exacerbation has happened. So what you have to go and what you have to look into, you have to see whether there was any precipitating factor, any social or psychological stressor that came into their life. And then let's say you find something out, you have to provide appropriate support or therapy and continue usual drug treatment. you did continue usual drug treatment, but there is no improvement, let's say, or on the first visit itself, you feel that acute drug treatment is required, then in that case, you can either add a short term sedative, it is usually a benzodiazepine, or switch to a different, more acceptable antipsychotic medication, or discuss medication choice with the patient. All right. So you either add a benzodiazepine or add an antipsychotic. Sorry, switch to another antipsychotic. We can also add an antipsychotic, right? And then you have to assess this patient over 6 to 8 weeks. If the treatment is ineffective after this, then switch to clozapine. Now, there are a few things that that they write below this. These are notes. So, okay, so let's say where there is prior treatment failure, but not confirmed treatment refractoriness. That means that you do not know whether they are treatment resistant. What you can do is you can give a trial of olanzapine or risperidone, which Dr. Sherry's mentioned, maybe better options than quetiapine. So usually, so Maudsley says trial of olanzapine and risperidone. Olanzapine, because of the wealth of evidence and superiority over other antipsychotics. If you remember, there was a Casey study as well, which actually told that olanzapine was doing so much better in terms of reducing the symptoms, although it had greater impact on metabolic profile of the patient, but overall the symptom reduction was very good with olanzapine. All right. There is another thing. There's another thing it mentions is before considering clozapine, ensure adherence to prior therapy using depot or LAI formulation or plasma drug level monitoring of oral treatment. So there are two ways that Maudsley says, and also even in TRIPS criteria, it is given in the same way, that how to ensure whether the patient was adherent to the medication or not. The first thing is they should at least have been given um, a long acting injectable for 4 months, because it takes 4 months for a long acting injectable to reach the steady dose in the plasma level in the plasma. All right. And either this or you also take the serum levels of that drug. You check the serum levels of that drug. All right. So this like a serum level. So it's like this nanogram per liter of the levels should have been present before you consider that, okay, this is treatment resistant. All right. So this is what they say. Now moving on to relapse or acute exacerbation, where you found out that the compliance is poor in this patient. Now in that case, what you do is you understand what was the problem. You see lack of insight or support was there. You discuss with the patient and consider depot or LAI antipsychotic medication. All right. Let's say they said that, okay, I forget it, or they are disorganized, or let's say they have poor support. There's no one to support them to give them the medications. In that case, you simplify the drug regimen. So instead of a lot of drugs, you just are like, okay, you know what, you just have to take one drug in the evening and that is all. You simplify the drug regimen and then reduce any anticholinergic load, because why do we have to reduce anticholinergic load in this case? Forgetfulness or disorganized, anyone? Anyone? So anticholinergics will block, let's say, well, muscarinic receptors, and cholinergic acetylcholine is responsible for learning, memory, and attention. So when you are blocking the action, sorry, um, yeah, I'll just tell you in this way that we usually give anticholinergics. Let's say trihexyphenidyl in the patients with Yeah, in the patients with when we give antipsychotics. Why? So that we remove the side effects of antipsychotics, right? So, but we also know that THP is going to worsen their cognition. Worsening of cognition is present with anticholinergic drugs, and that is why we try to reduce the anticholinergic load in these patients, in any patients. All right. And then consider compliance aids. So compliance aids are like a Medidose system, which is present in the UK. I'm pretty sure if people from the UK might know about it. So what they do is they have robots or manual segregation of the tablets in like weeks, Monday, Tuesday, morning, evening, afternoon, so that patient does not have to think about taking the medication out the wrapper and then taking it. So they just prepare it completely and then dispense it to the patient. So it is easier for them. But it also writes that they are not a substitute for patient education. This is important. Aim is the ultimate aim, they say, is to promote independent living, perhaps with patients filling their own compliance aid. Okay, so this is important. Having first been given support and training, and then consider depot or LAI. We have poorly tolerated treatment. In that case, discuss with the patient and switch to antipsychotic medication. Let's say poorly tolerated treatment, and that is why patient left or is erratically compliant on this treatment. So that means there are probably some side effects. So either deal with the side effects or change the antipsychotic. All right, and use the LAI if patient agrees. So in any case, you see, LAI is something that we consider before considering a patient is treatment refractory. All right. So this is from Maudsley, and Dr. Shehri's already mentioned one thing that UK NICE guidelines mention. So this was last reviewed in September 2024, and this again, I just took the screenshot from Maudsley. So they have given a summary of NICE guidelines here. So in case of first episode psychosis, what they say is we can give oral antipsychotics and psychological intervention. NICE guidelines mention very precisely for psychological intervention. They actually focus on this thing a lot. Okay. So what they write is CBT or family intervention under psychological interventions. All right. Then there are a few things that they also say, but what we'll do is we'll not look into this because it's going to be a little bit otherwise problematic. So what I have done is I've compiled it here. So this is from Maudsley, but it is more or less same. It is very same as NICE guidelines, right? So when you're starting a patient on antipsychotics, let's say, so what are the things that you need to take care of? What are the baseline investigations that you need to do? So you have to take the weight of the patient, height, BMI of the patient. You have to check the waist circumference, pulse, blood pressure. Well, diabetic profile. They don't write diabetic profile, but you can learn it that way. Fasting blood glucose and HbA1c. You have blood lipid profiles. Prolactin is something that we don't usually do. If you think that this, so it has a star mark here that um, if you think that prolactin might be increased, for example, in cases of already patient is having amenorrhea and you want to check prolactin levels, so then that is when you are going to order the prolactin levels of the patient. All right. Then assessment of movement disorders, if any, and assessment of nutritional status, diet, and level of physical activity. All right. So before starting, record the following baseline investigations. Now, we have to keep monitoring and record all of these things. So what I've done is I've made a small chart here and it kind of covers nearly everything. So you have weight. So weight, pulse, BP, FB, fasting blood glucose, HbA1c, lipid profile, ECG. Prolactin is not something that we do routinely. It is done only in special cases. So you're going to do the baseline investigations of all of these. All right. Now, of course, as the patient, so this is important. It is not like you are going to take weight only after 6 weeks. No, when the patient is going to come visit you after 2 weeks, that is also when you're going to take the weight of the patient and measure the vitals of the patient. So don't get confused with this. But it is like It is like this is this protocol that you have to do it no matter what in these intervals. So weight of the patient should be taken at 6 weeks, 12 weeks, 1 year, and then annually. Similarly, pulse and BP every 3 months. 3 months, 1 year, annually. We have fasting blood glucose, HbA1c lipid profile at 12 weeks. So 3 months, 1 year, and annually. And similarly, ECG, again, ECG is also not indicated in every patient. If you think that the patient might be having some cardiovascular problems, that is when we take the ECG of the patient, all right, or already a congenital heart issue. That is when we do it. Okay, why do we take the ECG of the patient? Why is it necessary before we start the treatment? Anyone?
To check the QTC interval,
Yes.
because a lot of antibiotics increase the QTC interval and increase the risk of certain cardiac death.
Yes.
Yeah.
That's correct. Antipsychotics, many antipsychotics, actually all, but we have like similar, we have like high QTC and then moderate and then low, very low effect on QTC. So antipsychotics have effect on QTC and they prolong the QT interval, which can be life threatening. And if a patient already has a prolonged QT interval, which we usually consider more than 450 milliseconds, so we usually do not prescribe a patient an antipsychotic that can prolong this QT interval more if they already have more than 450 milliseconds of QTC interval. All right. Okay, so there are a few more things. They also say record the following. So they say efficacy, including changes in symptom and behavior on every follow-up. Side effects of treatment, taking into account overlap between certain side effects and clinical features of schizophrenia. For example, they say you have to check whether it is akathisia, whether it is agitation or anxiety, or whether it is the overlap between the two. Maybe it is both. All right, adherence of the patient, that is compliance of the patient, and the rest of this that we have already discussed. Okay, so Maudsley also writes a note on ECT. It says that, let's say, in case of treatment resistant schizophrenia, and you already started this patient on clozapine. In this case, and clozapine, you checked clozapine after, let's say, 2 to 3 weeks, and clozapine is still not working. In that case, you can augment with ECT, modified ECT. Right? So this is what they say. And the studies, like evidence is very good. While the evidence remains, they say inconclusive, but there are many studies that have already, it tends to support ECT augmentation of antipsychotic treatment, particularly clozapine, as a potential efficacious and relatively safe augmenting strategy. Okay, next thing. Okay, use of other medications in case of schizophrenia. So we have antipsychotics. Okay, we are only going, so this is from 5-year findings for in schizophrenia studies, with negative symptoms. So we are talking about the negative symptoms. So what are the antipsychotics? Let's say if a patient comes to you and they have predominantly negative symptoms. So what are the antipsychotics that have proven to be very effective with these negative symptoms? So these are the amisulpride, cariprazine, aripiprazole, clozapine, and roluperidone. All right. So this is from the past 5-year studies. Okay, just learn these. This is very important. So cariprazine, aripiprazole, so it's not Braxy here, not written, but these come under the same class. And then we have amisulpride, we have clozapine, and roluperidone. All right. Then let's say there are negative symptoms, but again, also depressive symptoms predominate. All right. So in that case, you can add SNRI or SSRI. They have not mentioned any SNRI or SSRI, but they have just mentioned you can add antidepressants to these patients. For negative symptoms, they also mention that intermittent theta burst stimulation and deep brain stimulations. Location is left dorsolateral prefrontal cortex. This also works very well. So this is called as somatic therapy. Then we have psychotherapy with CBT, which works well. We have rehabilitative measures, for example, cognitive remediation therapy, social skill training, and exercise. And then others, N-acetylcysteine with a dose of around 1200 to 3600 milligram per deciliter. So all of this is actually given in Maudsley as well. But I have not taken the screenshot of the pictures, and I've just written like all in all. Like these are also some of the measures that have been helpful with negative symptoms in schizophrenia, right? Okay. This is from American Psychiatric Association Guideline 2020. May not be important, but I have taken this because there are a few things that they describe very well, which is, for example, let's say um, now, we are considering the side effects of antipsychotic medications. All right. So now I will ask first, and then we go into this one. Okay. So my first question is that your patient presents with acute dystonia, or let's say rigidity, bradykinesia. What is a drug that you're going to start? Okay. Coming next. You have akathisia, tremors. Then you have tardive dyskinesia. Okay, first, tardive dyskinesia. When does it usually occur in cases of, treatment with antipsychotics? So all of these are side effects from antipsychotic treatments. And when does tardive dyskinesia usually occur in these patients? And what is tardive dyskinesia? What are some of the symptoms that are present in tardive dyskinesia? Anyone? Just
Basically,
take.
stiff, jerky movements.
I'm sorry, can you please repeat that?
Stiff, jerky movements, uncontrollable movements.
Mm-hmm. Yes, for
Like,
example, you may have perioral movements.
yeah, like lip smacking is
Yeah. What else?
grimacing, doing some, you can be doing, some uncontrollable movements with your arms or legs.
Yeah. All right. I'm not able to, I don't know, like I think your whatever you're saying is correct. Actually, these are very involuntary movements. Even akathisia is involuntary movement. But these are the movements. It is, so what is happening here is, let's say perioral movements would be there, very grimacing facial expressions would be there. So tardive dyskinesia is a chronic presentation of antipsychotic medications, side effects of antipsychotic medications. You're right there. But why does it occur? Why does tardive dyskinesia occur? What is happening here? So what I am going to do is I'm going to add a note here. Okay. Um, okay. Let's just discuss the side effects first. Okay. What are the side effects of antipsychotic? Anyone? Like just randomly tell me the side effects of antipsychotics, and you have to be like cautious about these side effects. Yes.
Okay, so there are metabolic side effects, right? So metabolic side effects, you gain weight, you can have you can acquire diabetes, you can have high blood pressure, you can have um, like you can have okay, sorry, give me a
Yeah,
moment.
you're right. You're right. So this happens because It has, because all the antipsychotics have a tendency, they have a big volume of distribution, they have a tendency to, fit into the fat cells, and of course a lot of other mechanisms are going on there. So yes, so this is definitely there. There's metabolic side effects. Yeah. Similarly, you can also say sedation is also very common with these medications, right? Okay. What else? So what happens with dopamine blockage? So our antipsychotics are actually blocking the D2 receptors in striatum. There is basal ganglia. So what is happening with blockage of the D2 receptors? Definitely hallucinations and delusions are reducing. Okay, so since Dr. Sherry's, you were not there in the schizophrenia class, I did a one schizophrenia session in which we discussed about all the pathways um, that are responsible for generation of symptoms in schizophrenia, and all the important, well, neural circuits in schizophrenia. There are four: mesolimbic, mesocortical, nigrostriatal, and tuberoinfundibular. We have discussed this already. I think I uploaded this video before. So if you want to go through it, you can go through it. It's like it's a little big one. I think it's a more than 2 hour video, but you can watch it like at 2x or something. So yeah. So mesolimbic and mesocortical pathways. These are the ones that are actually producing symptoms of schizophrenia. So what? So for example, mesolimbic is going to produce delusions and hallucinations, so positive symptoms. And mesocortical pathway of schizophrenia is producing negative symptoms. So D2, so D2 is blocked in striatum. D2 is blocked in striatum. D2 receptors are blocked in all of these four pathways: mesolimbic, cortical, nigrostriatal, and tuberoinfundibular. Now, due to blockage of mesolimbic in these two, sorry, yeah, so here dopamine is decreased and here dopamine is increased. So that is also one thing there. So let's say mesolimbic, we block the D2 receptors, delusions and hallucinations have improved here. But because of blockage of D2 receptors in nigrostriatal pathway, so let's say you're blocking D2 receptors, you're not letting dopamine function in nigrostriatal pathway. What will you have? Parkinson's like symptoms, similar to what happens in Parkinsonism. So, what happens in Parkinson's? Usually, dopamine is decreased in Parkinson, and that is why we give levodopa or carbidopa in these patients. So, where is it decreased? It is decreased in nigrostriatal pathway. So, this is idiopathic Parkinson. So, we call it Parkinson disease. But because Parkinson is happening, Parkinson like symptoms are happening due to another cause that we know of, we call it Parkinsonism or Parkinsonism like symptoms. All right. Now, because of blockage of D2 receptors on nigrostriatal pathway, we'll have movement problems in here. They will be very similar to what you see in Parkinson's disease. You will see bradykinesia. They will walk very slowly. You will see that there will be rigidity present in their arms, usually in their joints, even in legs. There will be tremors in these patients. So some of they might even have, well, masked faces is like anyways a symptom of schizophrenia. They have a very blunt effect, so we don't keep it here. Okay, so these are some of the symptoms that can be present. And then acutely, let's say you have blocked the dopamine receptors suddenly, too many. Too many dopamine receptors have been blocked very suddenly, acute dystonia can occur. So all of these, like which we saw here, over here, acute dystonia, rigidity, bradykinesia, is due to initial blockage of dopamine receptors in nigrostriatal pathway, or let's say striatum. All right. So yeah. Now, not only this, it is also due to, there is one more reason to it, and that is, well, when dopamine, so dopamine and acetylcholine have like this kind of, so when dopamine is increased, acetylcholine is decreased. When dopamine is decreased, acetylcholine is increased. So they have this inverse relationship. So because of increase in acetylcholine, these symptoms also precipitate. Now, when these symptoms precipitate, because of decrease in, let's say, increase in acetylcholine, we tend to give anticholinergics in these patients. Can you give me examples of some anticholinergics that we give in these patients?
Anticholinergic examples, procyclidine.
Yeah, you're correct. Very, 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 very good. Okay. Sorry. Yeah. So anticholinergics like procyclidine, as Dr. Sherry's mentioned. Then we have, let's say, trihexyphenidyl. We have benztropine as well. So all of these are anticholinergics that we usually give in the side effects that are like acute side effects. Okay. But with chronic side effects, we tend to change our way of treating the side effects. All right. So akathisia and tremors are also acute side effects. Sometimes akathisia can also relate to chronic side effects. So when tardive dyskinesia is there, similarly, there is like akathisia, which is chronic, which is different. So what we are dealing with here is, let's say, acute side effects. So in case of tremors or akathisia, what you can give is, well, over here it is written, akathisia or antipsychotic therapy. On antipsychotic therapy, you can either give benzodiazepines, for example, clonazepam, lorazepam, or you can also give beta blockers to these patients. We usually prefer beta blockers because they help a lot with tremors and, of course, akathisia as well to settle the patient. So, akathisia here, what they describe is inner restlessness, not outer. It is inner restlessness, these patients, right? We already discussed this one. Acute dystonia or Parkinson's, treated with an anticholinergic agent. Let's say patient comes with tardive dyskinesia. Now, tardive dyskinesia is chronic presentation of side effects of patients already on um, antipsychotics. So, what is happening is because you have blocked the dopamine receptors, sorry, this is presynaptic neuron, this is postsynaptic neuron. You have blocked the dopamine receptors for a very long time, and it's kind of decreased the dopamine as well already because you don't have enough receptors to work on, let's say. So what is happening here is these dopamine receptors have become very sensitive, the ones that are present and are not blocked. They have become super sensitive. So, whatever dopamine is released from this presynaptic neuron, when it goes and attaches to these D2 receptors, they get hyperactivated and they fire haywirely, like anyways, like they don't care about it. And that is why you have, you have the symptoms that you see in tardive dyskinesia. For example, the perioral movements. There's a name for that. I forgot the name. I think it starts with C. There's like a perfect name for those perioral movements that occur in there. And we also discussed the other ones. So this is what is happening. So what we do here is we try to, well, reduce the dopamine further. So we block the VMAT2 receptor. VMAT2 receptor is responsible for packaging the dopamine into the vesicles, right? So we are blocking this receptor which is present inside this presynaptic neuron, and therefore when dopamine is not packed, it won't be released. So we are decreasing the release of the dopamine further. So when we decrease the dopamine release, it won't go attached to these receptors, and therefore doesn't matter. The sensitivity won't matter. So we give VMAT2 inhibitors, reversible inhibitors, in case of severe dyskinesia or tardive dyskinesia. All right. And the examples of these are valbenazine and deutetrabenazine. All right. So valbenazine is FDA approved for tardive dyskinesia, and this one is FDA approved for both tardive and dyskinesia and Huntington's chorea. All right. So, guys, are things making sense to you all, or is it like too much? I don't know. People here, are you guys following? Hello. Hello. Dr. Sherry's?
Oh, yeah, sorry, I'm here. Sorry, my daughter is crying, so I'm listening, but yeah, otherwise I'm listening to you.
Yeah, are we following? Like, are we following? Are you understanding?
Yes, yes, yeah.
All right, wonderful. So, this is the last section for schizophrenia. So, indications for treatment duration. So, why, like, what indication for lifelong treatment in use of antipsychotic medications? So, this is from Conceptual Textbook of Psychiatry, that is CTP, and they have written some of the factors for the lifetime treatment of schizophrenia. So, single factor based, if they have had a suicidal attempt, comorbid substance dependence, or family history of psychosis with poor outcome. In that case, no matter what, the treatment is usually long term or lifelong. All right. The other ones are history of 2 episodes in the last 5 years. So, this is symptom based. Symptom based, they are giving 4 things. So, history of 2 episodes in the last 5 years, presence of residual symptoms, and multiple relapses on treatment, and when treatment is tapered. So, in that case, also, we are going to keep them on lifelong treatment. So, this is it. So, these are the indications for treatment duration. Okay.
Sorry, can you please repeat that?
Yeah, sure. So, okay, so I'm not, so let's say you tell me, like, what do you think would be the indication for lifelong treatment for the patient of schizophrenia? What do you think? Just think
Well, if
about it.
they are not, well, if they got residual symptoms, so they're
Yeah.
still, or there's a risk of harm to others and to self-expose.
Mm-hmm. Yes. So what I have done is I have like reduced them into in the way I can learn. So they're like single factor based. For example, if there has been a history of suicidal attempts, so no, you're not going to taper medications for this patient. This patient is going to take long-term medications or lifelong medications from you. All right. Let's say presence of residual. No, another one is family history of psychosis was there with poor outcome. Let's say there's a family history of psychosis and history of suicide present in the patient's family because of psychosis or whatever reason. So that means no, you're not going to taper the medications for them. You're going to give them long term medication. Then, if they're also having comorbid substance dependence, whether it is nicotine, whether it is alcohol, or any other substance, in that case also you will be giving them long term medication. So these are like single factors. And let's say symptom based. So symptom based, you saw like in the last 5 years there were 2 episodes of schizophrenia, um, and the patient would relapse even on treatment or when you try to taper the treatment off. So in both of these cases you're going to give long term treatment or lifelong treatment to these patients. And finally, if there is presence of residual psychotic symptoms, that these residual psychotic symptoms are never going away. For example, some patients will have auditory hallucinations for life. Now, if you're going to taper the medications for them, the exacerbation of symptoms will happen. So, other symptoms might also come back. So, you know that residual symptoms are present in these patients, so we cannot taper the medications for them. So, all of this, that's it. All right. Okay. So, Dr. Shahriz, we covered like completely everything on schizophrenia and with the treatment. There's something else as well. It's like TRIP, which I told you earlier, treatment response and resistance in schizophrenia. Now, this was already discussed in section. So it is a little bigger part. So I'm not going to discuss it here again. But if you want, then I may have some of the notes. I will share it with you, so you can just have a read, and then you'll be able to understand what are strips. Okay. So do you want to continue? Let's continue with the mood disorders, or do you want to like just take it off?
It's up to you and other
Yeah,
the other people.
that's fine. All right, great.
Yeah, let's go ahead.
Yeah. Great. So, okay. So, everyone, we covered with the schizophrenia and ICD-11 criteria and management. And if there is something else you guys want to add, we can add here as well. Like, do you like want to add something else, Dr. Sherry's, like regarding the management of schizophrenia that you already know of or you have already read, and I might not have mentioned it here?
No, I think I've covered almost everything. I haven't done paper A, but for paper B, so all the medications that you have mentioned for the side effects, for example, you do need to know the different names of like all the names of VMAT we use for VMAT medications, or anticholinergic medications, etc. So all those things are like the actual names are very important.
All right, great, great. So I did not mention this, I just skipped it. But yeah, yeah, these are the medications that we do usually use here in the first generation part, in the second generation part. So these are like minimum and maximum doses of the medications mentioned in European Medicines Agency labeling. And again, this is taken from Maudsley.
Yes, and you need to remember these as well, paper D, and also what doses we will use for first episode of psychosis. Because usually they're a bit lower, often half of the usual dose. For
Okay. Yeah. Are you saying that is like there is a dose regimen for first episode of first episode of schizophrenia?
um, so first episode of psychosis, not schizophrenia, but first
Okay.
episode of psychosis, usually we start with lower doses. Um, I just remember doing a few MCQs about it, in paper B. That's all. So they do ask you about it, and that was something that I had memorized.
All
And the
right. All
maximum
right.
dosage.
All right. Got it. Got it. Okay. Great. So yeah, with first episode, we usually start with the lower doses and then we titrate it upwards, but we go with only minimum effective dose. We try not to increase the dose. Okay. Okay, great. Okay, let's move on with the ICD-11 criteria for mood disorders. Okay, so how are these mentioned in ICD-11? What I've done is this is the printout of the ICD-11 I took and just took the picture of that. So it is done, given under mood disorders, and initially what they have done is described mood episodes in ICD-11. So what they have done is described depressive episode, manic episode, mixed episode, and hypomanic episode, and then they go on to describe the disorders according to these episodes. So you have bipolar and related disorders, you have depressive disorders. Um, so this is what comes under. Wait, yeah, mood disorders. So this is all coming under mood disorders. So because anxiety and fear related disorders is again another subgroup, just like mood disorders. Okay. Okay. So yeah. So what they write in the under mood disorder in ICD-11 is that primary types of mood episodes, which we already discussed, all of these four, which we are going to discuss in detail, like what is covered in depressive, manic, mixed, hypomanic episode, and then they tell about well how they have segregated bipolar disorders and depressive disorders. So for bipolar disorders, they have given well bipolar type 1, type 2 disorders, bipolar and related disorders, cyclothymic disorders, other specified bipolar related disorder, and bipolar or related disorder unspecified. Similarly, for depressive disorders, they have included the following. They have included single episode depressive disorder, recurrent depressive disorder, dysthymic disorder, mixed depressive and anxiety disorder, other specified, and finally unspecified depressive disorder. So we are going to look into all of this, and this is not like this is very simple, simplest thing. Um, okay, before going here, let's just brainstorm things. Okay, so can anyone tell me what are the features of depressive episode? How do you how do you say that a patient is having depressive episode? Um, if you know about from ICD-11, tell it from there, or if you don't know from there, just tell it generally. What do you think? What symptoms should be present? Let's say essentially, and what symptoms should be present? Maybe it's okay if they are present, or generally, whatever.
Okay, so as one of my, so I don't know, someone else had mentioned earlier, so most symptoms should be present. Uh, so symptoms, sorry, there are two core symptoms essentially. So one is low mood and the other one is anhedonia, so loss of interest and pleasure. So the at least one of them should be present. And in addition, several other symptoms can be present. So they can be, poor concentration, poor self-esteem, excessive guilt, you're sleeping more, so sleep disturbances, appetite changes, suicidal thoughts. They can be psychomotor agitation and or retardation. Um, I think I mentioned poor concentration, right?
Yeah,
Attention and concentration.
yeah, I think you've
So
mentioned
these
a
are
lot of them.
Yeah,
Yeah.
these are essentially, so they should be present for most days out of like 2 weeks. So the minimum criteria is like 2 weeks, most or
Okay,
all days.
great. Yeah, yeah. Very good. Very, very nice. So I think you already remember the criteria for ICD-11. Very well
Yeah.
described, all of them. So I there is one difference here that they have given. So what you mentioned for like two symptoms. Well, so we are coming into the depressive episode, mood episode descriptions. So Dr. Shahris mentioned that well, two symptoms need to be present. That is low mood and anhedonia, that is decreased interest in activities. But ICD-11 is mentioning something else. So yes, this was present in ICD-10. I agree, but ICD-11 has changed it a little bit. ICD-11 has done three things. The first one is they have they have created clusters of these. So they have said that the symptoms are present in three types of clusters: affective cluster, cognitive behavioral cluster, and neurovegetative cluster. And they have separated the symptoms according to these clusters. All right. And then they say that at least, so total symptoms that need to be present are five, including one from affective cluster. So at least one symptom out of two should be there from affective cluster. So, so that means out of so affective cluster says either depressed mood or markedly diminished interest or pleasure in activities. So these two are there, but you don't have to have both of them in essential criteria. You can have either one of them, and at least four symptoms from either cognitive cluster or neurovegetative cluster. Okay, so let's understand what they have mentioned in cognitive behavioral cluster. So think about thought. That's it. What is present in your thought? What is present in the patient's thought and cognition? So they had reduced concentration. Dr. Sherry's, you have already covered everything, but we are just dividing them into clusters here. You said belief of low self worth and guilt. Then there is hopelessness, and there is recurrent thoughts of death. So this is also a content, that is thought content. So all of this is going to come under cognitive behavioral cluster. So I'm repeating this again. So the patient will have decreased concentration, may have low self-worth and feeling of guilt, may have hopelessness, and recurrent thoughts of death. Okay. and even evidence of attempted suicide. Now, when we come to neurovegetative cluster, think about vegetative cluster, everything related to our vegetative life. So it is sleep, it is appetite, it is psychomotor, it is activity, is it agitation or it is retardation? It is also, it's not written here. Okay, so they have mentioned sexual desire in here, in affective cluster. It can also come in vegetative cluster. This may include a reduction in sexual desire. Okay. And reduced energy. So all of these are 4 symptoms from neurovegetative cluster, 4 symptoms from cognitive, and 2 from affective cluster. I hope it makes sense. Sleep, appetite, psychomotor agitation, retardation, and reduced energy. And you already mentioned that you have total duration for 2 weeks. Okay, at least 5 of the following characteristics for 2 weeks with at least one symptom from the affective cluster. Okay, so this constitutes depressive episode, and this results in significant impairment in personal, family, social, educational, occupational, or other important areas of functioning. Okay, moving on to the severity. So, how do you describe whether this depressive episode is mild, moderate, or severe? Anyone? How do you know? How do you say that, okay, this patient is having a mild episode, moderate, or severe episode?
Generally, for a mild depressive episode, the symptoms are few, the intensity is not as isn't that high, and the person seems to be, like they're functioning all right. There might be, some issues or difficulty, but essentially, for the most part, the life hasn't been affected too much.
Yeah.
Whereas with moderate, so more symptoms, greater intensity, um, etc. With severe, again, there's a lot of impairment in daily functioning, right? It affects the daily life quite a bit, and especially if there's any psychotic symptom, then the depression would be considered severe.
Yeah.
So
All right. Yeah, with severe, it will be in even more intensity of the symptoms. Yeah. So you're right. You're right. You're completely right. ICD-11 describes these episodes according to the intensity of the symptoms and functionality of the patient. So, as you said, none of the symptoms in mild depressive episode would be at an intense degree. And individual is usually distressed, some difficulty in continuing function, but they're okay in one or more domains. One more thing, in mild depressive episode, there are no delusions or hallucinations. Now they have described moderate. Now this is also important in ICD-11. So what is the difference between ICD-10 and ICD-11 here? Is in ICD-10 they only described psychotic symptoms. So with or without psychotic symptoms in severe episode of depression. But in ICD-11 they have also included moderate for both psychotic presence or absence of psychotic symptoms and severe. So this is one more difference between ICD-10 and 11 here. And yeah, so, and in moderate case, as you told, several with marked degree, considerable difficulty in functioning without psychotic, so no delusion. With psychotic, similar thing, but with delusion or hallucination. Similarly, severe depressive episodes, many or most symptoms with marked degree, serious difficulty in continuing function of most domains, no delusion with without, and with are delusions present. So yeah, done. Then manic episodes. Okay, what are the essential criteria present in manic episode, and what are the other criteria that we look for manic episode?
manic episode is usually for 1 week. However, if a patient gets admitted, then it doesn't matter how long it has been
Yeah.
since they've been symptoms. The symptoms are, of course, elated mood, irritable. So that's one. Otherwise, yeah, grandiosity, pressured speech, um, can have a formal, thought disorder, increased energy, poor sleep, um, um, they have earlier grandiosity, of course. Um,
Mm-hmm.
yeah,
Yeah. Yeah. Then we have goal-directed activity, sociality, and well, you have already mentioned the delusions part. Yeah, let's just see what are the things that they have mentioned. So, in manic episode, ICD-11 says that in essential criteria, both of the following features needs to be there for at least 1 week. And as you rightly mentioned, there must be an extreme mood state is observable or reported, characterized by either euphoria or irritability or expensiveness. All right. So significant change from the individual's typical mood should be present. And the second essential criteria is increased activity or subjective experience of increased energy is present. Any of them. All right, so this is important. Both of them should be present. And it says then several of the following symptoms can be present. So, how I have learned them is through, well, the two things that we do in mental status examination, that is speech and thought. So, in speech, we have rate, tone, and volume that we see. So, I have star marked the things that are usually increased in this patient. So they will be volume is increased. So increased talkativeness is there. Pressure of speech is increased. So rate of speech is increased. So pressure of speech is increased. All right. Then in thought, flow and form is increased. So flow is increased, let's say. So if flow is increased, that means they might be having flight of ideas. They might be having even form is there is a problem with form. They might be having loosening of association. Then, with content, as you rightly said, grandiosity would be present. There might be vegetative clusters of the things of the symptoms might also be present. For example, decreased need for sleep, increased sexual desire, and increased psychomotor activity in terms of behavior. That is reckless behavior, goal directed activity, increased sociality. So, yeah, so this is how I have learned them. So, you see, increased talkativeness, pressure of speech, flight of ideas, rapid or racing thoughts, illogically formed one idea to the next, increased self esteem or grandiosity, decreased need for sleep, distractibility. All right, this I forgot. Distractibility is present. Then impulsive, reckless behavior. Example: individual impulsively pursues pleasurable activities without the regard of their potential negative consequences. An increase in sexual drive, sociability, and goal-directed activity. Now, significant impairment needs to be present in all of these domains, and patient it must be so significant that you understand that the patient might require intensive treatment, example hospitalization. All right. Okay. So mixed episode. Okay, tell me how are you going to tell that this patient is having a mixed episode? Anyone? So how are we going to tell that the patient is having a mixed episode? So we already discussed manic episode, we discussed depressive episode. Now we are discussing for the mixed episodes. So in case of mixed episode, ICD-11 says that must criteria is having altered mood. So, altered mood should be present. So, what kind of alteration of the mood can be present in this patient? It could either be, well, it could either be euphoric, no, not euphoric, but it could either be depression, it could either be irritable mood, dysphoric mood, any of these can be present. Depressed, dysphoric, euphoric, or expansive mood. All right. And it should at least be present for 2 weeks, along with presence of manic and depressive symptoms. So both of the symptoms are present simultaneously. So it's not just manic symptoms, it's not just depressive symptoms. The features of manic symptoms, for example, well, increased talkativeness, increased energy, um, features of depressive symptoms, for example, dysphoric mood, decrease interest in daily activities, all of these can be present. And even, well, both of them mixed episode can also be characterized by having crying spells. All right. So a lot of things can be present simultaneously, or they can also be present with a fluctuation. For example, course is rapid fluctuation, day-to-day fluctuations might be present, or hour-to-hour fluctuations might also be present in this patient. Okay. So total duration is 2 weeks in this case. Now, it also says that when depressive and manic symptoms alternate rapidly during a mixed episode, such a fluctuation may be observed in mood. Example between euphoric and euphoria, sadness, or dysphoria, and emotional reactivity. Example, the patient may present with flat affect or even intense or exaggerated reactiveness, and they may even fluctuate between hours. So in the morning they were very happy, by the evening they are very dysphoric, very irritable. All right. And even cognitive functioning might be fluctuating with periods of activation and inhibition or slowing of thoughts, attention, and memory. All right. Now, this actually poses significant impairment in all the domains of the functioning and may be accompanied by delusions or hallucinations. Okay. Now, this is one important additional clinical feature. Now, let's say this patient was on antidepressants. Okay. You were treating the patient for depressive episode, and then the patient lends up into what you suspect is a mixed episode. Now they are no more depressed. They have been switched to a feature of bipolar consisting of both depression and manic episodes, that is mixed episodes. When is it that you're going to say that it is a mixed episode? This is important. If you have stopped the antipsychotic treatment, after the treatment is discontinued, and so it writes that if you stop the antipsychotic and the symptoms still persist. So it says that a mixed syndrome arising during antidepressant treatment, example medication, electroconvulsive therapy, light therapy, transcranial magnetic stimulation, should be considered a mixed episode if the syndrome persists after the treatment is discontinued and the full diagnostic criteria of mixed episodes are met after the direct physiological effects of the treatment are likely to have receded. All right. So even after you think the antidepressant treatment is no more effective and still the symptoms are persisting, in that case, you will consider this patient is having mixed episode rather than a reactive episode after starting an antidepressant or giving the transcranial magnetic stimulation. All right. So this is important. Now, moving forward with hypomanic episodes. Now, can anyone tell me, like, how do you call, like, what is the difference between a manic episode and a hypomanic episode? When do you call a patient might be having a hypomanic episode? Anyone in the guest list? Anyone who has joined? Dr. T, Dr. Nothing 8059, Dr. Shahriz. Dr. Sherry's is a little bit like she's having probably a problem with her internet connection.
Hi, sorry. Yeah, I was. Sorry, did you ask me something? I've just
Yeah,
joined.
yeah, it's all right. So, can you tell us the difference between a manic and a hypomanic episode, perhaps?
Yeah, sure. Yeah, sure. So hypomanic episode essentially, so the symptoms are less intense, not affecting your your daily life. So that's essentially, and there are no psychotic symptoms. That's a major difference. And of course, duration. Hypomanic, we diagnose hypomania if the symptoms have been going on for 4 days, whereas for mania, as we had discussed earlier, it needs to be for 1 week or unless the patient gets hospitalized. So if someone has hypomania, so they would be elated, overconfident, over sexual, going on shopping sprees, that kind of stuff, but they're still going to their jobs. so they have increased energy and everything, but they're going to work. Their daily life hasn't been affected. There are no psychotic symptoms from what I remember. Yeah.
Yes, yes. You've covered everything very, very well. So, yeah, you see, 4 days is something that ICD-10 writes probably, but in ICD-11 they have not mentioned days here. They said for at least several days. They took this away, the 4 day thing, but the rest of the things that you mentioned are correct, completely correct. So, what is important here is the symptoms are less intense and functionality is maintained in this patient. So, persistent elevation of mood and increased activity, and all of the symptoms, as you said, similar to manic episode, but marked functional impairment is not there. And as you mentioned, psychotic symptoms, that is, hallucinations and delusions in hypomanic episodes, will not be present. If, let's say, the intensity is less, but hallucinations or delusions are present, let's say grandiosity is present, then then you are not going to call it hypomanic episode. It has already converted into a manic episode. So this is, yeah, hypomanic episode. Not sufficiently severe to cause marked impairment in all of the domains of functionality. Okay. All right. So we discussed all of the symptoms here, all of the episodes. So we discussed depressive episode, we discussed manic episode, mixed episode, and a hypomanic episode. The next thing that we are going to do is we are going to understand how ICD-11 has actually used these episodes to identify or to cluster the illnesses into bipolar and, well, depressive disorders. Okay, so they have distinguished both of them. Okay, so let's just complete this. I've written something here for boundary with manic episode. I think we have already discussed it, so I'm not going to. Yeah, boundary with ADHD. So we are actually talking about hypomanic episode. How are you going to differentiate hypomanic episode from attention deficit hyperactivity disorder, especially if hypomanic episode occurs in a young child? Yes. Okay. So
Hello, can you hear me?
yes, I can hear you.
Mhm.
I can. Who is this speaking?
So,
Doctor?
yeah, it's Tam.
Yeah. Hi, Dr. T.
Sorry, hi there. Thanks a lot for this great effort. I think, yeah, I was having issues with the network, so I'm glad you can hear me now.
Yeah.
So yeah, so obviously there will be a few things, but mainly the pervasiveness of the symptoms. How long they've been there for, and what age they started. So with the hypomanic symptoms, you'd expect it to be a few days. But in, say, if it was ADHD, you would expect it to be there in much longer than that. So that can be one way.
All right. Yeah, that's correct. Yeah, I think you covered it. So, yes, the age onset is usually less than 12 years when we talk about ADHD. And as you said, that pervasiveness of the symptoms. So, this persistent of the symptoms in ADHD is not going to be episodic,
Yeah.
which is seen in hypomanic episodes. And then they
Yes.
are not tied to changes in mood and energy. This is also important. So, it writes that they
Yeah.
are not temporarily tied to changes in mood or energy and are not
Yes.
accompanied by mood elevation. So these are some of the important things that will make a difference between a hypomanic episode and ADHD.
Yes.
All right. All right. So this completes our section with the understanding different types of episodes that ICD-11 describes. Now let's come to different disorders that they describe according to the episode. So the first cluster that they have given is bipolar and related disorders, and they have, well, incorporated bipolar type 1, type 2, cyclothymia, and other disorders in this one. So let's start with bipolar type 1 disorder. Okay, can you tell me what is the difference between a type 1 and type 2 bipolar disorder? Hello? I think there might be some internet issues. Okay, so I'll just describe it. So we have type 1 and type 2 bipolar disorders, and with type 1, we say that there is a manic episode. With type 2, the only difference is if you have a hypomanic episode, then you say it is a type 2 disorder. All right. But with type 1, manic plus minus depressive episode can be present. But with type 2, hypomanic plus depressive episode needs to be there. So, unlike ICD-10, so ICD-10 actually gives a description of, well, manic episode. And then it says bipolar type 1 disorder, sorry, bipolar affective disorder. All right. So what it says is, well, it has actually, so by ICD-10 segregated first episode mania. So they said first, you have to call, if there is only one episode, which is mania, which is a manic episode, then you classify it under first episode mania. And but let's say if they have a manic episode and then a depressive episode as well, both of them present, then it changes to bipolar disorder in case of ICD-10. But when we talk about ICD-11, they have basically taken down this description. They have the classification is a little bit changed in ICD-11. So even with the presence of one manic episode, now you're going to call this patient is having bipolar type 1 disorder. That is what you're going to call. So you don't have to have another depressive episode in this patient. So at least one manic or, okay, they also write a mixed episode. I forgot to mention this. At least one manic or mixed episode is present. That we call that the patient is having bipolar type 1 disorder. Now, all right. Depressive episodes might be present, might not be present. In the course of illness, hypomanic episodes and depressive episodes might also be present. Even then, the patient will be considered the type 1 bipolar disorder. All right. Now, but with case of type 2, that is bipolar disorder, bipolar type 2 disorder, with hypomanic episode, there must be a depressive episode also present. Only then will you consider this as a type 2 disorder of bipolar. All right. So that is it. Types of, so at least one manic or mixed episode. And although a single manic or mixed episode is sufficient for a diagnosis of bipolar type 1 disorder, the typical course of the disorder is characterized by recurrent depressive and manic or mixed episodes. Although some episodes may be hypomanic, but history of at least one episode of mania or mixed episode should be present. Then specifiers, how are you going to segregate bipolar type 1 disorder? So they have given specifiers and they should include, well, current mood episode, severity, and psychotic symptoms. Okay, so they have described a current mood episode, they've described the severity of this episode, and whether the psychotic symptoms are present or not, or whether the patient is in remission or not. So what they have done is, I'll write it again here, what they have done is for mixed episodes and manic episodes, they have given specifiers only for psychotic symptoms. That is either bipolar type 1 disorder, current episode mixed, current episode manic, with psychotic symptoms or without psychotic symptoms. When we talk about hypomania, well, you know that in hypomania, psychotic symptoms are not present. So they have given it singly. They have not described either psychotic episodes with them or severity. Now, severity, if you remember, we only discussed severity with depressive episodes. We have not discussed severity with manic or mixed episodes or hypomanic episodes. So severity is only considered in depressive episodes, and this will be divided into mild, moderate, or severe, or unspecified severity. Okay, so that means the severity specifier is only going to be applicable for depressive episodes. So what you're going to say is patient is having bipolar type 1 disorder, current episode depressive, moderate, with or without psychotic symptoms. So again, with mild depressive episode, you're not going to put this subspecifier with or without, because we don't say that with a patient having a mild depressive episode is going to have hallucinations or delusions. But with moderate and severe, again, the specifiers would be expanded to positive or negative, with or without psychotic symptoms. All right. Okay, guys, are you with me? All right. So I'll just keep moving forward. I hope people are with me here. So we have, you can see here. So this is the specifiers that they're given, which we have already discussed in very brief. So what they have done is bipolar type 1 disorder, current episode manic. So manic without psychotic symptoms, manic with psychotic symptoms. That is what we mentioned. Mixed and manic with or without psychotic symptoms. So mixed, let's just cover the mixed as well. Over here, current episode mixed without psychotic symptoms and mixed with psychotic symptoms. All right. Now, hypomania only singly will be given. So, bipolar type 1 disorder, current episode hypomania. With depressive episodes, we discussed that it would be mild, moderate, and severe. And with moderate and severe, without and with, as subspecifiers would be given, which we can see here. All right. And unspecified severity again with the depressive episode. Now, remission. With remission, specifiers would be present, but you also have to mention remission of which episode. So the most recent episode, you need to mention that. So with bipolar type 1 disorder, let's say the patient is in partial remission. You would say most recent episode is manic or hypomanic. Partial remission, most recent episode depressive. All right. Partial remission, most recent episode mixed. Or full remission. With full remission, you do not need to describe the last episode. Okay, so this is all. And then you have other specified bipolar type 1 and unspecified bipolar type 1 disorder. So if you can see, without psychotic symptoms, current episode mania, there will be no delusions or hallucinations. With delusions and hallucinations will be present. Then moving on, we have partial remission. Now, when do you call a patient is in partial remission? So the full diagnostic criteria of manic and hypomanic episodes are not meeting, but significant manic or hypomanic symptoms still are remaining. That is when you say partial remission is there. When do you call a patient is in full remission? That no longer any significant mood symptoms are present and the patient has reached back to their baseline. Okay. All right. So this was bipolar type 1 disorder. Moving on to bipolar type 2 disorders, we have at least one hypomanic symptom and at least, as I said, one depressive episode. All right. So both of these need to be present if you want to call the patient as having bipolar type 2 disorder. The only thing that separates bipolar type 1 from type 2 is the type of episode. Is it manic or is it hypomanic? All right. It is important to understand that there should be no history of manic or mixed episodes. Now, what are the specifiers? Specifiers would be same. You have to describe the type of current mood episode. That is current episode hypomania. With hypomania, there will be no further specifiers because you don't have to you don't require to give severity or psychotic symptom descriptions. But in case of depressive episode, you will have to give the severity, symptom description, and psychotic symptom description. So with depressive, we already discussed how you have to go. So with current episode hypomania, nothing is required. Current episode depressive mild, then we have moderate, we have severe, again without or with psychotic symptoms. Then again with partial remission, most recent episode. depressive, partial remission, most recent episode hypomanic, and unspecified. All right. Okay. So are people with me here? Like Dr. T, can you hear me? Can you tell me what is a cyclothymic disorder? How do you define a cyclothymic disorder? Or what do you think is a cyclothymic disorder in terms of, well, symptoms, in terms of duration of illness, and in terms of differentiating it with a bipolar disorder? I think there might be some internet issue. So I'll go into cyclothymic disorder. So what is happening in cyclothymic disorder? As the name suggests, so because it cannot be bipolar type 1 disorder or type 2 disorder, that means, and this is something like cyclothymic. So there must be a cycle that is going on here between maybe depressive symptoms and manic symptoms. But these manic or mixed or depressive symptoms are not meeting, probably not meeting the diagnostic requirements of bipolar type 1 or type 2 disorder. And that is why they have kept it separately here. Plus, not only this, the duration of illness, total duration of illness is quite more. It was just 1 week here, and it is 2 years here. Okay, so let's just see. So the features of hypomanic and depressive episodes would be present. Okay, so it's not manic. Okay, it's only hypomanic episodes. This is important for cyclothymic disorder. Sorry. Hypomanic and depressive features are present. And very much decreased in intensity as compared to the hypomanic or depressive episode criteria. So they are not meeting the diagnostic criteria. And the total duration of illness is 2 years. Okay. And what is important here is must present should be mood instability. So fluctuations in the mood would be present in this one over an extended period of time. Okay. So they're saying hypomanic periods may or may not have been sufficiently severe or prolonged to meet the diagnostic criteria. Now, this is very, very important that during the first 2 years, there have never been a 2 week period of period where the diagnostic criteria of the depressive episode has been met. This is important. So you can only call a patient as having cyclothymic disorder if this patient never, ever in the 2 year period had a depressive episode. Because let's say they had a depressive episode in this 2 year period, then this might either convert into single episode depressive disorder or it may convert into bipolar type 2 disorder. It is no longer going to be cyclothymic disorder. But the catch is after 2 years, if after 2 years depressive episode happens, then in that case, we are going to make a comorbid diagnosis. So we'll say the patient is having single episode depressive disorder plus with cyclothymic disorder. And then there is another catch here, which we already discussed, that let's say a depressive episode or a hypomanic episode occurs with full severity. And the diagnostic criteria for both hypomania and depressive episode are met, then we are going to change this diagnosis to bipolar type 2 disorder. So another thing regarding cyclothymia is there's significant distress about experiencing persistent mood instability, or there might be significant impairment in all the functioning domains of the life. Well, may or like not all, but or either family, social, educational, occupational. Okay, how do you classify patients as children are having cyclothymic disorder? So, well, they might be having the same thing. Mood might usually be irritable, but the symptom duration is decreased. It is decreased to 1 year. Symptom duration is decreased to 1 year here. All right. Now, how do you differentiate cyclothymia with normality? So, what is the threshold that you're going to say that, okay, this is cyclothymia and this is well, this is a normal individual. So, normal variations in mood by a history of distress or difficulty functioning due to repeated occurrences of mood disturbances will be present in cyclothymia disorder. All right, patient would have significant mood distress. And if they are functioning, then the functioning is maintained by additional effort. And it writes it very, if functioning is maintained, it is only through significant additional efforts. All right. So this is cyclothymic disorder. Yeah, there are no specifiers for cyclothymic disorder. So cyclothymic disorder is either present or absent. All right. Okay. So next up, we have completed our everything regarding bipolar disorders, bipolar and related disorders. Now we are jumping into the depressive disorders. Okay. So, how have they classified depressive disorders? We already discussed the classification of depressive disorders. Just a second, guys. I think my battery is low. Yeah. I just connect to my charger. So give me a sec. Fine. All right, we're back. Okay. So what they have done is they have segregated them into, well, single episode depressive disorder. If you come back here, if you see here under the mood disorders, depressive disorders include the following. It is single episode depressive disorder, recurrent depressive disorder, dysthymic disorder, mixed depressive and anxiety disorders, and other specified and unspecified. So we're going to look into the details of these four. Very, very simple, because we already now understand the four types of episodes that they use to segregate all of these episodes here in bipolar and depressive episodes. So I'll just go back down. And yeah. So in single episode depressive disorder, then there is a single depressive episode. All right. So there will be what will happen with single episode depressive disorder, that it should meet the criteria of a depressive episode. Presence of one depressive episode, only one. So that is why we call it single episode depressive disorder. So presence of one episode of depressive, depressive episode. And so that means it should be present at least for 2 weeks, right? And then what they have done is they have, well, specified some of the specifiers using the severity of the single episode of depression, whether the presence of psychotic symptoms is there or not, and the remission, whether the patient is in remission or not. Okay, so it's very similar to the ones that we have already discussed. If you remember, how are we going to segregate single episode depressive disorder? So any depressive episode, we have mild, moderate, severe, and unspecified severity, right? And then with psychotic symptoms, moderate and severe would be present either with or without psychotic symptoms. So and then with remission, so there will be either partial remission in all of these cases, mild, moderate, severe, or there can be full remission where you don't have to specify what was the last episode. Okay, so if you see here, single episode depressive disorder mild, we have moderate, severe, with or without psychotic symptoms. We have unspecified severity, currently in partial remission, currently in full remission. Okay, so they are not describing whether it was a mild or moderate episode. They are saying just partial remission here. Then we have other specified and unspecified depressive disorders. Okay, moving on to, okay, now this was single episode depressive disorder. Very, very simple. Anyone can tell me, when do you call a patient is having recurrent depressive disorder? There is only one difference, that is the duration of remission. What is the duration of remission of the first episode? That needs to be present in order for you to say that the patient is having recurrent depressive episode. So you have first episode, then there is a duration, the patient should be in remission, and then the second episode occurs. And then this is called as recurrent depressive disorder. Okay, so what is this duration? Anyone? This is 3 months duration. So if you can see here, so, okay, you have not written 3 months here, but I read it somewhere 3 months. So it says at least 2 depressive episodes included a current episode, that is the second episode, separated by several months without significant mood disturbances required for diagnosis. It's usually 3 months difference. All right. Okay. And it also says, let's say the patient was in dysthymia, and then a mood disorder appears. And then the patient, how would you call it a recurrent depressive disorder? If the patient goes back to the chronic dysthymic symptom, and then after a few months, again a depressive episode occurs. So you're going to say that this patient is having recurrent depressive episode with dysthymia. Okay? Because with dysthymia, also a recurrent depressive episode can be present, because dysthymia can precipitate, let's say, a trigger or a stressor came here at this point in life, and then this precipitated into a depressive episode, a full-blown depressive episode rather than dysthymia. And then they came back to normal, not like normal in terms of not baseline, but dysthymic temperament that they were already having. And then they come back again having a stressor in life. So this is the diagnosis that you're going to give to the patient. Okay, so what are the specifiers they've used for recurrent depressive disorder? Again, same thing, episode mild, current episode moderate, current episode severe with or without psychotic symptoms, then unspecified severity, partial and full remission, and other specified and unspecified. Now, this is recurrent depressive disorder. All right. Now we move on to dysthymic disorder. When do you call a patient is having dysthymic disorder? So it is very similar to cyclothymic disorder. Okay, very, very similar to cyclothymic disorder. It's like if cyclothymic disorder is the baby of bipolar, dysthymic disorder is the baby of depressive episode. Okay, so if you remember, in cyclothymia, must was the lability of the mood. Similarly, in dysthymia, must is that the patient is having persistently depressed mood. Okay? And if you remember, in cyclothymia, the symptoms of hypomania and depressive episodes are present, but not to the intensity to diagnose these. So very less intensity. They do not meet the diagnostic criteria. Similar to that, the symptoms of depressive episode will be present in dysthymic disorder, but to very less intensity that you're not able to diagnose this patient as having a depressive disorder. Okay? So, and again, total duration in case of cyclothymia was more than equal to 2 years. Similarly here, more than equal to 2 years. So remember, dysthymia is the baby of depressive episodes, single episode depressive disorder, and cyclothymia is the baby of bipolar type 2 disorder. Okay. So yeah, so it writes the same thing. See, persistent depressive mood is there, lasting for 2 years or more, for most of the day, more days than not, and reported by the individual as feeling down or sad, or observed by the patient's informants as tearful or defeated appearance, is required for diagnosis. In case of children and adolescents, the depressed mood may manifest as pervasive irritability. The depressed mood is accompanied by additional symptoms typically seen in depressive episode, so in milder form. So this could be the similar cluster of symptoms which we saw in depressive episode: diminished interest, reduced concentration, self-worth, hopelessness, decreased appetite, increased sleep, disturbed sleep or increased sleep. So it's like a reversal of vegetative symptoms, or you can say atypical type of dysthymic disorder. Diminished or increased appetite, low energy or fatigue. Okay. There was one more thing. If you remember in cyclothymia, we saw that in the first 2 years, there must never be 2 weeks where depressive episodes criteria is met. Similarly, in the first 2 years in dysthymia, there must never be a 2 week period where depressive episode criteria is met. This is important. Okay, only then will you call this patient as having dysthymia. Okay, while brief symptom free period can be present, this is also important, that brief symptoms free period is present, but not for more than 2 months. Let's say this patient is having dysthymia since 1 year. For 1 month, the patient was okay, very, very well, back to normal, and then had started having dysthymia again. So yes, this patient is diagnosed of dysthymia. Like currently 2 years period will be given to them. But if this symptom free period is more than 2 months, then no, you will break the diagnosis here. The same diagnosis would not be made for them. All right. Okay, so that was dysthymia. Now moving on, we have the next one. So we discussed single episode depressive disorder, we discussed recurrent depressive disorder, and we also discussed dysthymia under depressive disorders, depressive and related disorders. All right. Now we are coming to mixed depressive and anxiety disorders. So what is the difference? What is it about mixed depressive and anxiety disorders? Okay. So in the case of mixed, why are we saying that the patient is having mixed depressive and anxiety disorder? With the name itself, we understand that that the symptoms of depressive episode probably is present in this patient, and the symptoms of anxiety are also present in this patient. But both of these symptoms are not enough to meet the diagnostic criteria of either a depressive episode or an anxiety disorder independently. So, symptoms are present both of depressive episode and anxiety disorder, but they are not severe enough or severe in intensity enough, or the number of symptoms are not completely meeting the criteria for either a depressive episode or an anxiety disorder. Because if they were meeting both of them, then we would give a comorbid diagnosis. So we will say single episode depressive disorder with, let's say, anxiety disorder, whichever it is. If it is generalized anxiety disorder, if it is XYZ, whatever it is. But since it is not meeting the criteria for both of them, but the symptoms are present, so we say it is a mixed depressive and anxiety disorder, and it comes under depressive disorders, right? Umbrella. Okay, so we have presence of both depressive and anxiety symptoms for most of the time during a period of 2 weeks or more. So the total duration here is very less, only 2 weeks of the duration is required. So it says that depressive symptoms and multiple anxiety symptoms might be present, not meeting the diagnostic criteria. Depressive symptoms may include depressed mood or markedly diminished interest or pleasure of activities. And multiple anxiety symptoms may include feeling nervous, anxious, not being able to control worrying thoughts, fear that something awful may happen, having trouble relaxing, muscle tension, sympathetic autonomic nervous system activation, for example, having dry mouth, having sweating, palpitations, etc. Okay. Okay, this is it. And the symptoms result in significant distress or significant impairment in all of these domains, all or one or all of these domains. So this was about mixed depressive episodes. And yeah, so this concludes our section on depressive disorders. we have unspecified, and we have another one that is not otherwise specified. Well, they have also given, so this does not belong to the 6th chapter. Premenstrual dysphoric disorder comes under GA 34.41, which is different from the classification that we are discussing right now. We are actually discussing the classification 6A. All right, and this is different. It is GA 34.41. So, but they have included it so that we can understand, because this also comes under our this also comes under our treatment indications. So, premenstrual dysphoric disorder, what is it? So, premenstrual dysphoric disorder is how are you going to diagnose a female is having a premenstrual dysphoric disorder? So, ICD-11 writes that during a majority of menstrual cycles within the past year, the patient is having, so majority of menstrual cycles within the past year, patient had a pattern of mood, somatic or cognitive symptoms that were present, typically of, let's say, depressive episode, several days before the onset of menses, and then it starts to improve within a few days after the onset of menses. And then they are minimal or absent within approximately 1 week following the onset of menses. Okay, so this is when you diagnose the patient as having a premenstrual dysphoric disorder. So they say that the symptoms include the following: at least one affective symptom, such as mood lability, irritability, depressed mood, or anxiety. So any one of them should be present, and additional somatic or cognitive symptoms. What are somatic and cognitive symptoms that might be present in this patient? Well, somatic symptoms, for example, joint pain, breast tenderness, swelling of extremities. All right. Cognitive, for example, concentration difficulties, forgetfulness, or even hypersomnia and lethargy or overeating might be present in these patients. All right. So that is about premenstrual dysphoric disorder. So that concludes our section on various disorders that we wanted to read. We needed to read for ICD-11 diagnostic criteria for mood disorders. So we completed our section on this one as well, the mood disorder descriptions over here. So we completed all of these. We saw these. We saw what are bipolar and related disorders. We saw depressive disorders, and we completed the premenstrual dysphoric disorder as well. Now, in the next session, we will continue with the treatment guidelines for the mood disorders. So we will be we will be segregating them and discussing them separately for depressive disorders and for bipolar disorders. Okay, so in bipolar we will have manic and depressive episodes. We'll have different guidelines for them as well. And then with depression, it's not usually the same. We usually discuss depressive disorders in a single guideline. And then we will also discuss about treatment-resistant depression. All right. So, and then we will go on to discuss regarding the other, right. The other things that we needed to discuss in today's class, that is, we will discuss other anxiety-related disorders. We will also discuss OCD and dissociative disorders. And if the time permits, we will also discuss the ICD-11 criteria of autism spectrum disorder, disorders of intellectual disability, and ADHD. The treatment algorithm of these will require a lot of dedication and time. So I may not discuss the treatment algorithm in the next session, because anyways our next session is going to be a little bit bigger anyways, like larger than this one. So yeah, we'll discuss this. Is anyone here with us, with me? Dr. T, can you hear me? Dr. T and Dr. Nothing. Dr. Nothing, could you tell us your name? I think there's some internet issue towards your sides. Dr. T, so this is all I could prepare for today. I will be preparing the rest of for the rest of these by tomorrow, and then we can take a class again for the rest of them for OCD, other anxiety-related disorders, dissociative disorders, and ICD-11 criteria for childhood disorders, that is child psychiatry. All right. And if possible, could you please? Okay, you're can hear you. Oh, great, great, great. Okay, it's all right. It's all right. Okay, sorry, because I cannot check my chats usually when I'm sharing my screen on the same tab. So yeah, so great. Could you please give a message on the group, like text a message on the WhatsApp group, drop a message on the WhatsApp group, so that I know like who are you, because I'm not able to like Dr. Tease it. Yeah, it's fine. It's fine. Like, what's your name and where are you from and what are you preparing for right now? So that we can connect more. And which paper are you preparing for? Paper one or paper two? We can have a chat on the WhatsApp group. Yeah, sure. And then, yeah, I'll end this meeting for now. I hope you enjoyed enjoyed the session. I hope you got something out of the session as well. All right. I think there is a poor network. Okay, wonderful, wonderful. Thank you for letting me know. I'll end the session now. We can continue this again tomorrow. Okay, bye-bye. Good night. Yeah, you're very welcome.